Okay, so I think we can get started now. Thank you so much for joining us this lunchtime. I hope everyone has something to eat, something to enjoy during this webinar. We are delighted to be here with our lovely panelists. And I think what we'll do is we will start with some introductions before we get stuck into the presentation today. So you are joined here today by myself, Saj. So I am the Business Development Manager for Veterinary Solutions at bioMérieux for Northern Europe. My background, for anyone who isn't familiar with me, is human diagnostics for just over 10 years now. And about 2 years ago, I sort of moved into the veterinary space. And as somebody who is very passionate about One Health, I am delighted to be here. I'm also joined by Pierre Rupert. Pierre is our Global Product Manager for Veterinary Point of Care Solutions at bioMérieux. Pierre he was actually a vet for 15 years before joining bioMérieux, and I think it's safe to say that Pierre is pretty passionate about diagnostic innovations in this space. We are also joined by Professor Nicola Menzies-Gow. Professor Nicola Menzies-Gow is from the Royal Veterinary College in the UK. Nicola spends her time teaching and research and also doing clinical work and is highly knowledgeable in this area as a professor in equine medicine. So we're delighted to have Nicola here with us today. And last but not least, my colleague David Smart. David is a global business development manager who also was a vet, and very specifically an equine vet, for around 8 years before joining bioMérieux, and actually graduated from the Royal Veterinary College. So these are your panelists today. I'd also like to just point out that during the presentation, you can submit questions. There is a Q&A box. It should be on the top right-hand side of your screens. Feel free to submit those questions and we will answer those at the end of the presentation. You will also notice a symbol with a piece of paper and a paperclip. There are some resources there that you can download and view during the presentation. We have pre-recorded the main presentation today for what we hope will be a much more enjoyable and smooth viewing experience. So without further ado, let's get started with that presentation.
Hello everybody and welcome to this webinar. I am Pierre Rupert, Global Product Manager for Veterinary Point of Care Solution in bioMérieux. And today I'm very honored to have with us Professor Nicola Menzies-Gow from the Royal Veterinary College.
Hello.
Hello. And Saj Lashani from bioMérieux UK.
Hi.
Our objective today is to discuss the challenges in managing the two main equine endocrine disorders, being Cushing's disease, also known as PPID, and equine metabolic syndrome, also known as EMS. This webinar will include an interview followed by a Q&A session. Professor Menzies-Gow, may I call you Nicola first before we start? Yes, Nicola. So Nicola, as a leading expert in equine endocrine disorders, you have built a strong expertise as well in clinical science and research as well. What do you consider to be the typical progression of symptoms in PPID and EMS, starting from the earliest stages and most subtle signs until the most advanced stages?
So if we start with PPID or Cushing's disease, it's slightly complicated by the fact that there are signs that appear earlier in the disease and signs that appear later, but the signs can also be divided into sort of how high your clinical suspicion of the disease is in the animal. So we divide the signs into those that give you a high clinical suspicion, a moderate, and a low clinical suspicion. And the clinical suspicion is mostly based on how certain you can be that that clinical sign is associated with just the PPID rather than any other disease. So the clinical sign with the highest clinical suspicion are the hair coat changes. So that might be regional hypertrichosis. So they essentially retain the hairs on the legs or maybe in sort of patches on the neck, or it might be what we call generalized hypertrichosis. So they retain the winter hair coat over the whole body. Certainly hair coat changes occur both earlier in the disease and later in the disease. it's not necessarily sort of a progression that they start with regional changes and they progress to generalized. The individual horse will have its own changes and it will do its own thing. And we know that owners are much better at recognizing those hair coat changes than the vet. So you're definitely worth talking to the owner about whether they've recognized any changes in the hair coat, because they pick up the changes when they're much more subtle compared to the vet. So it is the hair coat changes that have the strongest suspicion, but then sort of the next changes that occur are sort of lethargy, weight loss, changes in sort of the appearance of the horse. So some of them will develop bulging of the supraorbital fat pads, or they'll lose their top line muscles. So you get sort of degree of muscle wasting. And some of them even develop a pot-bellied appearance. But certainly those changes occur further down the line when there's been greater progression. And then the one clinical sign that causes the most degree of problems, both for the owner and the horse, and affects its long-term prognosis, of course, is the laminitis. And that can occur either earlier on in the disease or later on, depending on the individual animal. So that's the Cushing's disease, or the PPID. The equine metabolic syndrome, again, is it's similar and different. So again, you get laminitis in animals with equine metabolic syndrome. And we know that whereas before we used to think that the animal had to be overweight or obese to have equine metabolic syndrome, we've now decided that there is what we call a lean phenotype, or horses can have an ideal body condition and still have equine metabolic syndrome, because the one thing that they have to have is insulin dysregulation. And obviously you're not going to see that by looking at the animal. We've done studies to show that nothing that the owner or the vet can look at will be able to predict the insulin dysregulation status of the animal. So yes, you might have an animal that the owner says it's overweight and I've tried all kinds of things and I can't get it to lose any weight, and it's had several bouts of laminitis. But you can still have an insulin dysregulated animal that is a normal body condition and it hasn't yet had its first bout of laminitis, and everything in between.
Well, thank you for all this information. Very clear. It appears that sometimes basically the symptoms are quite the same. Based on your experience, do you see a clear difference between these two affections and the way they affect horses? And maybe do you see sometimes cases where they occur at the same time on the same animals?
So the sign that it obviously occurs in both diseases is the laminitis. So pretty most animals with equine metabolic syndrome are at risk of getting laminitis at some point in their life, depending on how severe their insulin dysregulation is. But the animals with Cushing's disease, or PPID, it seems to be a subset of animals. So only between 1/4 of animals with PPID seem to develop laminitis. So we used to think that pretty much all animals with PPID got laminitis, but that was based on studies where they only looked at animals with quite advanced disease. So now we recognize the disease and we look at it a lot earlier. We've realized that actually it is only between 1/4 of those animals that get laminitis. But the ones that get laminitis are the ones with insulin dysregulation associated with their PPID. So that's the commonality, that both diseases, it's the insulin dysregulation that's driving the laminitis risk for those diseases. So which is makes it important that you go looking for that in these animals. But it is possible to have both diseases. Quite whether one occurs first or one triggers the other, again, we're not quite sure as far as the research goes. Is it that they always had the equine metabolic syndrome and nobody ever tested them, and then with age then they developed the PPID and they were going to do that anyway, and so they happen to have EMS and now they've developed PPID? Or we don't know whether it's in the equine metabolic syndrome, is it some kind of changes associated with the insulin dysregulation and the other effects on the body that also then affect the pituitary and cause the development of the PPID? So they're not separate events, one leads to the other. So at the moment, yes, you can definitely have both. So you need to go looking for both. But we don't know whether one causes the other or not currently.
And you talked also several times about the progressivity of the disease, laminitis being the latest stage sometimes. Um, what is your view about the true value of early diagnosis in these diseases?
Obviously, the sooner you diagnose an animal with either equine metabolic syndrome or PPID, the sooner you can then put in measures to manage the conditions. So both conditions you manage rather than cure. It's not like we can give the animal, even with the PPID, the pergolide doesn't cure the condition, it just replaces the lost dopaminergic inhibition. So all of them are going to, if you took away the therapy or you changed your management changes, are still going to have the underlying disease. So the sooner you start putting those things in place, then hopefully you then start to improve the clinical signs that the animal has. You'll reverse the hair coat changes, you'll improve the lethargy, you'll improve the laminitis. So if you improve, for example, with equine metabolic syndrome, if you improve the insulin dysregulation and you bring down the insulin concentrations, then you reduce the laminitis risk. So you reduce the chance of them having another episode of laminitis, and therefore you reduce the risk of them getting pedal bone changes that mean that you end up euthanizing the animal. So the longer you leave the animal untreated, we think that then you risk them then developing an episode of laminitis that will result in you not being able to treat that episode of laminitis.
What is the role of veterinarians in this aspect to guide the horse owners towards this early diagnosis? What recommendation do you usually do to your clients when you have any early suspicion of these diseases?
So as soon as you have a suspicion of the disease, regardless of what the clinical sign is, it doesn't have to be the laminitis. It can be the hair coat changes, it can be lethargy, it can be weight loss. Then you need to test the animal, because the only way you can make a definitive diagnosis is either by measuring the ACTH concentration for the PPID or the insulin concentrations for the equine metabolic syndrome. So you as the vet or the owner, you can both have suspicions by looking at the animal, but in order to confirm it, then you're going to need to do some testing. So, and obviously it's only you as the vet that can do that. The owner can't, there's no sample, it's not a saliva test or a fecal test or anything. It needs to be a blood test. So you as the vet need to take the blood and then recommend the appropriate tests to get a diagnosis and then discuss how you're going to manage the condition.
So let's talk about diagnostic testing. Which type of test do you usually recommend? And when is it the best time to perform these tests?
So the tests for the PPID and the insulin dysregulation or the EMS are different. So if we start with the PPID, then usually the place that most vets will start is measuring basal ACTH concentration. So it's not a stimulation test. It's simply take one blood sample, measure ACTH concentrations. It's not a perfect test because there are things that interfere with the test, pain, stress, time of year, etc. But certainly it has good enough sensitivity and specificity. So it gets the answer correct enough of the time that it's the best place to start. And then for the equine metabolic syndrome or identifying the insulin dysregulation in those animals with PPID, the place that you can start is measuring a basal insulin concentration. But we do know that quite a lot of the time, basal insulin concentrations can be normal, but the animal can still have insulin dysregulation. And in order to rule out insulin dysregulation, if your basal insulin is normal, then you're going to want to do a dynamic test. So in both cases, if your basal concentration doesn't match your clinical suspicion, then there are dynamic tests to do. So for the PPID, you would consider doing a TRH stimulation test, but then you measure the ACTH response to the TRH. We used to historically measure cortisol responses to the TRH, but now it's been decided that measuring ACTH is better for that. And then the dynamic tests that we recommend for the insulin dysregulation are you can either do what's called an oral sugar test or an oral glucose test. So the oral sugar test involves giving the animal a set amount of commercial corn syrup which has got essentially sugar in it. So the most commonly used one is called Carolite corn syrup. And you give the animal a set dose of the corn syrup, and then you measure the insulin concentration a set time later to measure the insulin response to that oral carbohydrate. And that will give you a measure of the animal's insulin response to carbohydrate, because animals with insulin dysregulation will have an excessive insulin response to that. And then the other dynamic test that you can do, but I think gets done far less commonly, is an insulin tolerance test, where you actually inject the animal with synthetic or exogenous insulin, and you measure the glucose response to that, because in an animal that's insulin dysregulated, its glucose won't come down as much as it should do. But I would say most people in first opinion practice will measure a basal ACTH concentration, and then we'll measure basal insulin and or do an oral sugar test to look for the insulin dysregulation.
Okay, and you are talking about several types of adjustments that can be done when you receive the results of the test. Which practical advice do you give to veterinarians usually to avoid misinterpretation about these tests?
So when we're talking about the ACTH concentration, you need to make sure that the laboratory that you send the sample to is using what we call a seasonally adjusted reference range, because we know that animals have a normal seasonal rise, so the ACTH production by the pituitary goes up in the autumn. That's part of their normal metabolism. So if your lab's not using an adjusted reference range, then every single animal in the land will have an abnormal ACTH in the autumn. So you need to make sure that they're using an appropriate reference range at different times of the year. You need to make sure, ideally, that your animal hasn't got any other disease going on at the same time. It's not sick for another reason, because we know if the animal's ill, its ACTH will go up. And ideally, it's not in pain. So there have been a couple of studies that showed that mild laminitis isn't enough to make the ACTH go up, but certainly if they've got moderate to severe laminitis or another painful disease, ACTH is a stress hormone, so any pain might make the ACTH increase. So if you have the opportunity to wait until the animal's laminitis is better, then that would be preferable, and you can measure the ACTH to get your diagnosis of PPID or not, maybe a couple of weeks down the line. And then when it comes to measuring the insulin is affected by a whole array of different factors, some of which you can control for and some of which you can't. So, for example, we know it's affected by exercise. So ideally, the animal's not been exercised straight before you take the test. We know it's affected by feeding, because that's its job to respond to glucose in the diet. So it's okay for the animal to have had forage overnight beforehand, so hay, haylage, etc., but not had any what we would call breakfast bucket feed, short feed, whatever term you like. So not have any carbohydrate type based feed beforehand, because otherwise your insulin's going to increase. And we know that there are a few other things that will impact it, sort of even age, breed, sex, coat color, all kinds of things, but it's impossible to adjust for everything. So in an ideal world, if you take your insulin concentration from an animal that's just had forage overnight in the morning, because it's affected by time of day, before it's done anything, then you're going to get your most reliable result.
Okay, so taking a sample in the morning is something key also if we want to have reproducible results over the time.
Yes.
So thank you, Nicola, for all this information. Of course, with your position, you follow closely all the most recent scientific developments. Which recent advances in diagnostic methods or treatments do you find the most promising today?
So probably the biggest change is in the pharmacologic management of equine metabolic syndrome. So up until now, and still really, the main focus is on using diet and exercise to improve the insulin dysregulation, so to try and improve insulin sensitivity. And certainly in at least most animals, you would hope with owner compliance that would be sufficient. But there are certainly some animals that doesn't seem to be enough, or there are some animals with quite acute laminitis, so the laminitis pain is such that you want to do something sooner than that. So the drugs that have been employed most recently fall under the category known as the gliflozins. So ertugliflozin, canagliflozin, dapagliflozin are the ones that are most commonly used. So they've come from human medicine. So they're a drug that get used in people with type 2 diabetes and also metabolic syndrome. And they work by inhibiting the SGL2 receptors, so the sodium-like glucose transport receptors in the kidneys. And they stop those receptors reabsorbing the glucose that's been filtered at the kidney, so you urinate out the excessive glucose. And they've been used in the horses, so there are now an increasing number of publications in the equine veterinary literature. Mostly they're small-scale studies, but they all show promising effects on improving particularly the insulin dysregulation and also on the laminar pain, so the amount of pain the laminitis is causing. So they are a short-term measure, so the animals ideally shouldn't be on it long-term. It's not like the pergolide, which is lifelong therapy. So you use it in the short term whilst the diet and the exercise are having their effect. And you have to use the drugs in conjunction with the diet and the exercise, and also if the animal has PPID, the pergolide therapy, because again, it's been shown if you don't do those aspects of it, if you ignore the diet and you stop the pergolide therapy, then the gliflozins aren't able to have their beneficial effects on the insulin dysregulation. But certainly there are the group of drugs that seem to have the most promise at the moment for having a positive effect of animals with the insulin dysregulation.
And how does it affect your way of testing? I guess probably you have more and more interest in insulin testing in that aspect.
Well, certainly you need to monitor these animals. So if you're going to put them on the gliflozin, so say you choose ertugliflozin, then before you start the therapy, you need to have made your diagnosis of insulin dysregulation by measuring the insulin concentrations. But you also want to measure their triglyceride concentrations, because the main side effect that these drugs seem to have in the horses and ponies is that they cause high triglyceride concentrations. So you need to know what the value is before you start. So you've got a baseline value. And then the recommendations is then to repeat the bloods sort of at increasingly long intervals. So you would repeat it after 7 days, because a lot of them, the triglycerides goes up very quickly. So you would want to measure them of a week. Then you would probably want to measure them again after a month of therapy. And then you would want to continue measuring sort of every couple of months whilst the animal's still on the therapy. 1, to measure the triglycerides to make sure they're not going up, and 2, to measure the insulin to make sure that you're having that beneficial effect on the insulin dysregulation, because the drugs don't work in all animals. So there are a percentage of animals that it makes no difference to the insulin dysregulation. So you need to know what the drugs are doing in that individual animal in order to continue deciding, well, are we staying on the drug? Are we changing the dose? Are we altering our management, etc.? So you do need to monitor these animals pretty closely.
Very interesting. We have also seen some publication about a new metabolite called CLIP. Could you tell us a bit more about this CLIP?
So CLIP is a fragment of ACTH, so a part of it. And when we've done some studies with some of the ACTH assays, we found that CLIP interferes with those assays. So it gives you a much higher ACTH concentration than just the ACTH itself. So it's important in knowing how each assay for ACTH behaves, because you need to know, am I measuring just ACTH or am I measuring ACTH plus CLIP? And we don't know whether measuring both is better or not, because we don't have an idea on whether one plus the other gives you a better diagnostic test than the other. So at the moment, we try and measure just ACTH because we have a much better understanding of that hormone and sort of the numbers at which you would make a diagnosis of PPID or not.
Thank you. Also, you recently evaluated the VIDAS equine ACTH and the VIDAS equine insulin assays. What are your first conclusions after having tried these new assays?
So if we start with the insulin assay, we tested it against various other assays that are being used already in the veterinary market. So we tested it against the Immulite and the Toso and the Macodia ELISA, and it performed very well. Essentially, we looked to see how well did it agree with those tests. And all of them, it agreed very strongly, and we could use it to generate what we call cutoffs. So when it comes to insulin, what you really want to know is what's the laminitis risk for our individual animal. So we try and categorize them as low risk, medium risk, and high risk. And we generated those numbers for those risk categories from a very large cohort study that we did, where we followed a group of ponies that started off never having had laminitis. We followed them for up to 4.5 years and see who did or didn't develop laminitis based on their insulin concentrations. So we were able to use the cutoffs from that study and then work out the equivalent cutoffs for the VIDAS insulin assay. So we can use that assay to get the equivalent information. And then as far as ACTH was concerned, again, we compared it to the values that you get the Immulite 2000 assay and also the TOSO. And we found that the VIDAS agreed very well with the TOSO, but not so well with the Immulite. And again, we could use the cutoffs that have been derived for the TOSO machine for, yes, it does have PPID, no, it probably doesn't have PPID. And then we have that equivocal or gray zone in the middle where yes, maybe, no, maybe, depending on you have to put that together with the clinical signs that the animal's showing. But it didn't agree, as I said, with the Immulite, and that's probably to do with the way that the assay works and maybe the role of CLIP and the interference with the assay.
Thank you. Thanks a lot, Nicola, for all these answers. Now I have a question for you, Saj. Saj, you are responsible for looking after the veterinary market at BioMérieux Northern Europe. Could you tell us, please, what is VIDAS Cube?
So VIDAS Cube is the latest instrument in the VIDAS family. It's a family of immunoassay analyzers. There's actually a picture of it on the banner beside you for reference of what it actually looks like. So VIDAS has been around for a long time. The technology is alpha technology, so enzyme-linked fluorescent assay technology. It's been widely used in human clinical diagnostics. So the equine ACTH and the equine insulin assays are a welcome addition in the VIDAS family.
How does it work exactly?
Yes, so the VIDAS system, let's say, is alpha technology, so enzyme-linked fluorescent assay technology, and the test itself has these two components. So you have a spur, which is a solid phase receptacle, and you have a strip, which has the reagents already prepared in each of the wells. The spur is coated with antigens or antibodies depending on the assay, and it also acts as a pipette within the system, moving from well to well essentially. In terms of the hands-on time, it's about 2 minutes to prepare, pop the spur and the strip into the system, and you can walk away from it. In terms of what you get as an output, as results, you get qualitative or quantitative results depending on the assay. And in the case of the equine insulin and equine ACTH, that's of course a quantitative output that you would get for your result. I guess another thing to mention is, as these are compatible, they are color coded, of course, but the system will be able to tell if somebody, for example, uses the insulin with the ACTH or tries to accidentally mix and match, or if somebody forgets to put a sample in, there's an optical sensor that detects that. And I mention that because if there's anybody like me in the lab who's likely to forget adding a sample, it's just good to know.
Good. So if I understand well, we have a high technology in the reagent itself, a high technology in the system, and with that together, everybody could perform a test, if I understand well.
Yeah, so I say if I can do it, anybody can.
Okay. So great. And several times you use the word or the term equine insulin or equine ACTH. How these assays were developed?
Yeah, so that's a good question. So essentially, the team that's developed these assays are the same team that developed the IVD clinical assays that we have for VIDAS. And so it's important to note really that the samples used were solely equine samples in the development of these assays. So it's the same team, the same expertise, the same level of development that we expect.
but just important to note that the samples used were solely equine, and that's why their intended use is equine assays, or equine use, I should say.
So thanks, Ax, for all these explanations. Just before with Nicola, we spoke about ACTH and insulin testing in equine medicine. Tell us, why do you think these VIDAS tests will be suited for equine clinics?
Yeah, so I think one of the big things is that, we know that space is precious and the system is modular. For the majority of equine clinics, we actually expect a one module system to be sufficient. And this would take up, very little space on a bench. It gives a bit of flexibility in terms of being able to run a test and not be limited by having to maybe batch. If your workflow varies quite a bit, we know that there are sites, for example, that, from day to day, they might be running one test versus 12 to however many on another day or a different week. So it gives a little bit more flexibility in terms of having that ability to not have to necessarily batch, being able to run one test, walk away. So it's the flexibility, I would say, as well as the space that it takes up. As I say, it is modular, so you can build that up if the amount of throughput in that site does increase. You have the option to add another module, up to 6 of them. But essentially, it is, as I say, the one patient, one test, one result, as and when needed. In terms of consumables, you have what you need within the kit. So say that you've got the spur and you've got the strip. So in terms of consumable management, it's a little bit easier as well for busy sites that want maybe a bit more flexibility and have varying workloads, I would say.
Thank you. And so if I understand well, you can run one test at a time, but what is the maximum capacity of the system? How many tests?
Good question. So on a one module system, you have the ability to run 12 tests at any one time, and it has 2 sections. So each section has 6 that you can run. So in theory, if you were to use one section and you had, for example, 2 equine insulin assays running, and you wanted to start a third test and this was already in use, you could use the second section independently. Say it's modular, so that 12 is for the single module of the system. The ACTH test takes around 48 minutes to run, and the insulin around 20 minutes, just to give an idea of what that could look like in terms of how long the instrument is in use.
So I guess you can launch one ACTH on one side of the system and one insulin on the other side, if I understand well. Yeah. Okay. Yeah, it's very practical indeed. Flexible and fast. So thank you. Nicola, with your experience in endocrinology, what could be your best advice for practitioners who would like to internalize testing of ACTH and insulin today?
So you need to choose a system that will work for you, depending on your setup. We've mentioned how many samples you might want to run at once, whether you're only ever going to run a few or you're looking at something that needs really high throughput. And you need to decide on practical issues such as, for example, the ACTH needs to be taken and ideally sort of spun, and if you're not going to run it straight away, then chilled. So you need to decide whether you're going to be able to bring your sample straight back to the lab. Are you going to separate it and chill it first? So you need a centrifuge as well as your machine to measure your assays. But certainly, whatever machine you choose is what you need to then stick to, because we know that the different assays give different, although they all agree, they give different absolute values. So you don't want to sort of buy one machine and then, next year buy a different machine, because then you're not going to be able to compare your values for your animals as you're monitoring them over time. And then that's just going to complicate matters. So whatever system you think is going to work in your setup, and then stick with that.
Okay, thank you. And we have talked a lot about PPID and EMS. Of course, this was the topic of the webinar. But maybe you have other situations in which this test may be interesting.
So one that's of increasing use at the moment is measuring insulin concentrations to get an idea of insulin dysregulation prior to treating with corticosteroids. So whether that's systemic corticosteroids or, for example, intra-articular steroid therapy, because we know that there's a risk of laminitis associated with corticosteroid use in animals that have insulin dysregulation or other laminitis risk factors. And the risk is not there if they are normal, healthy animals. So certainly there's increasing interest in testing animals sort of what we call prophylactically, so before you use the steroid therapy, so that either you can have the conversation with the owner about the risk of steroid-associated laminitis and decide whether to proceed with that or maybe use something different in your joint therapy rather than a steroid. Or the owner then has a known risk, so they're making an informed choice to still use the steroids. Or the other thing that people are again starting to use is use the gliflozin therapy as a short-term therapy to improve insulin sensitivity prior to then treating with the corticosteroids. So they may give 5 to 7 days of gliflozin therapy first, then for example, use the intra-articular triamcinolone, continue the gliflozins for another few days, and then stop those and hope that that minimizes the laminitis risk. At the moment, there is some scientific evidence to support that. There have been some studies done in healthy animals and using the gliflozins beforehand with some of the intra-articular corticosteroids. Is there enough evidence to show that it definitely prevents all risk? I don't think we know that yet, but it is certainly something that vets are increasingly looking towards doing to try and minimize that steroid-associated laminitis risk.
So I guess this is time to conclude. Thank you very much, Nicola.
Thank you.
Thank you very much, Saj.
Thank you.
These were very insightful perspectives, and we highlighted how complex and progressive PPID and EMS can be, how essential early detection and precise monitoring are for an effective management. Also, we have seen that even if laminitis remains the most critical complication, early diagnosis and early signs require a very strong attention, and that testing is becoming central, especially with new treatments such as glyphosins. VIDAS Equine ACTH and VIDAS Equine Insulin assays provide veterinarians with precise and repeatable tools for long-term decision making. Thank you again, both of you, and thank you everyone for your attention during this webinar. We will now move to the Q&A session.
Fabulous. So we will now, as Pierre said in the video, move on to the live Q&A session. So we're here with you live. Please feel free to continue to submit your questions. We do have a few questions already to ask our panelists. So Nicola, I'm going to actually come to you first with a question, which is, if you were to propose a best practice approach, would you advocate systematically testing for insulin in addition to ACTH when faced with a suspected PPID?
Hi, afternoon, everybody. The answer to that would be yes, definitely, because we know that a subset of animals with PPID get laminitis, and we know that that subset is the subset that have insulin dysregulation, either associated with their PPID or concurrently with their PPID. We're not 100% sure whether it's the PPID driving insulin dysregulation or they have it alongside their PPID. But regardless of that fact, it's their insulin dysregulation that's driving the laminitis and therefore putting them at risk of it. And we also know those with insulin dysregulation have a poorer prognosis. So you need to identify those animals, because the pergolide treatment that you might recommend for their PPID doesn't seem to improve their insulin dysregulation status. So then you need to do additional management and or pharmacological therapies to deal with that insulin dysregulation. So it's going to influence your management and treatment choices, and also what you tell the owner as far as the animal's long-term prognosis is concerned. So yes, very important.
Thank you, Nicola. And I have another, well, I've got two questions, Pierre, that might actually, I might ask you them at the same time. So the first is, where is the product available? And the second is insulin run on serum? So I think it's probably a good shout to group those two together and ask you both in one go.
Thank you, Zach, for your questions. So today the product is available in France, UK, and Ireland. We are performing some studies in other countries, and we have a launch plan to open new territories for the coming months. So if you have any question about the availability in your countries, just as simple as reaching to us and on the bioMérieux website, and we will provide this information. About the sample type, so for these two assays, we have two different sample types due to the hormone composition that we are targeting. So ACTH must be performed on plasma, EDTA plasma, and insulin must be performed on serum.
Thank you, Pierre, for that. And actually, I'm going to come to you next, David. We've got a question here, which is, if I have a 1 cube, but my testing increases, how do I upgrade on capacity and how big is it?
Okay, thank you very much, Saj. Hello, everybody. Very good question. Obviously, sort of touched upon a little bit earlier during the webinar with regards to obviously the capacity of one particular cube. So we can run up to 12 tests at any one time with 2 compartments which are independent. But obviously, if there is a need to increase the throughput there, in fact, what's great about the cube system is that in fact it's modular. So we can actually have up to 6 cubes, so potentially up to 36 tests at any one time. That can be run on a sort of a single system or a single computer, as it were. And another advantage related to this sort of modular aspect, should you need it, is that you don't need to do calibrations, which is actually, we didn't mention that, but every 2 months. In fact, you can just do a calibration and your first module, second module, third module are all actually integrated into one calibration. So, you know, in that respect, you could upscale your VIDAS modules, but you're in fact just doing a calibration on one system.
Thank you, David. And we have another question, which I think is for yourself, Nicola. Is, having looked at the comparative data using immunoassay instruments, would you be comfortable using the VIDAS instrument and tests?
Certainly. So the study we compared various insulin and ACTH assays, and we found that the ACTH results with the VIDAS cube agreed very well with those from the TOSO assay, which is the machine that's being used more widely and certainly by the big endocrine labs in the UK. Such as Liphook, they use the TOSO now, and then actually they switched from the Immolite to the TOSO, and the VIDAS agrees very well with the TOSO. And then when we compared with the insulin assays, the VIDAS assay agreed with all of the insulin assays that we looked at, so the Immolite, the TOSO, the Macodia ELISA, so they all agreed very well. So I had no concerns with how well both assays were performing.
Amazing, thank you, Nicola. And we have another one, which I think actually is for you as well. Is what insulin monitoring protocol do you advocate once you have decided to treat with gliflozin, and would that change depending on the available gliflozin?
So the gliflozins that are used most commonly in the horses at the moment, it varies a little bit between country and as to what is available, because it definitely seems to vary a lot, because at the moment there's no equine licensed product. So you're reliant on either specials or human products. So the drugs that are getting used are the canagliflozin, the atugliflozin are the 2 most common, but also have been used dapagliflozin, and then certainly there is one drug company that's trying to bring to market velagliflozin, but you can't get that at the moment. So the 3 most common ones are the canagliflozin, the atugliflozin, and the dapagliflozin. They all, you would have the same monitoring process for all of them. So you need to have obviously undertaken your testing, first of all, to confirm that the horse has the insulin dysregulation, and then decided that in that individual case, rather than diet and exercise alone, you're going to use some kind of pharmacological management. Then the main thing that, well, there are two things that you need to monitor in these animals, both the insulin, so that you're seeing what the response is to your therapy, but also their triglyceride concentrations, because the main sort of significant side effects as far as the horse is concerned is that you can get hypertriglyceridemia. So these drugs can make the triglyceride concentrations go very high, and even into the realms of you being concerned about the horse getting hyperlipemia. So it's important that you monitor both of those. Usually you would measure them both sort of on day 0 as you're starting the drugs, because obviously you may well have done your insulin testing a little while ago and then had a conversation with the owner. So what you want is a baseline as you start the drug. It doesn't matter what it did 2 weeks ago, a month ago, etc. It's what it's doing today when you start the drugs. Then we would usually say at least measure the triglycerides after 7 days, because it certainly seems to be that if they're going to go very high, they go high quite quickly. So you would want to measure triglycerides at 7 days, and then you would measure both the triglycerides and the insulin probably at the 1 month, so the 30-day time point, again, because it's going to take a little while for your insulin to come down. So probably 7 days is too quick to judge it on your insulin, but certainly you want to check your triglycerides then. So you would measure them at a month, and then you've got to decide how the horse is doing, because the drugs are meant to be used alongside diet and exercise. They're not instead of, and definitely there's evidence to show that if you don't control the diet and also the PPID, if they have PPID as well, if you don't control those factors, then the SGLT2 inhibitors won't do what you want them to do by themselves. And the idea is that we're using those drugs in the short term whilst your management changes and or your PPID therapy are sort of having their beneficial effect. So we're aiming for short-term use of these drugs. So you shouldn't need monitoring for using the drugs themselves for too much beyond the 1 month, 2 month, 3 month timing, because by then you should hopefully have the insulins under control and be looking to take the horse off the drugs and be relying on the diet and exercise alone.
Fabulous. Thank you so much, Nicola. And back to you, Pierre, on this one. Can you talk us through the key scientific challenges that arise when developing the equine-specific ACTH assay compared to assays designed for human use? So this is something we touched on during the presentation, but actually it'd be really good if you could expand on that as well, Pierre.
Good question, very interesting, and a bit a tricky one. Maybe most of you don't know, but the tests that are used widely on the market for equine testing come from human health and were developed on human samples, which does not mean that they don't work, but of course they are not really equine specific. And due to some slight differences in the hormone composition or in the sample type, it may have some impact. What does it mean to develop a very specific equine test? It means that at each stage of the development process, we select all our raw materials and we adapt the formulation, and we verify that it is really compatible with equine sample. It has a huge interest, in particular because we talked about it. For example, CLIP is a metabolite which may interfere with some tests, and in that case we are able during the development to ensure that this is not the case for VIDAS equine ACTH. Basically this is an additional effort during the development, but when we come to the field with this test in terms of support, it is really a key differentiator for us.
Perfect. Thank you, Pierre. We do have another question, which I think we're back to you, Nicola. This is another interesting question: is how should we interpret borderline ACTH results, especially during transitional seasons?
Oh, that's a difficult one. The trouble is we know there is a grey zone or an equivocal zone or whatever you want to call it. So we know that if your ACTH is low, you can be pretty confident the animal doesn't have PPID, and if it's very high, you can be pretty confident that it does have PPID. But there's that range in the middle where it maybe does, maybe doesn't, and then that's when we have to bring in our clinical suspicion. So you have to take into account the age of the animal, because the older the animal gets, the higher your clinical suspicion is going to be. So if your animal is only 10, it's, you know, the age makes it quite unlikely to have PPID, whereas if it's 20, you're going to be much more sure that your PPID is more likely. You also need to take into account the clinical signs that the animal has, because we know that there are clinical signs with a high suspicion of disease, the one being the hair coat changes, so the hypertrichosis. So, for example, if you've got a 20-year-old animal with hypertrichosis and an equivocal ACTH, you're going to be pretty confident that it has the disease. Whereas if you have an animal with the clinical signs that either fall in the moderate clinical suspicion category or the low clinical suspicion category, then you're going to have to sort of put that together with the age and the ACTH concentration and decide. So some of those equivocals are actually easier to interpret than others, because the age and the clinical signs will guide you. Some are still difficult. So if you've got some moderate clinical suspicion in a horse that's 12 and its ACTH is kind of at the low end of the suspicion, then your clinical suspicion overall is going to be much lower. And you have to decide on balance, what do you think is most likely? You're the one as the vet looking at the animal, and you can decide either on balance, I think it does, or on balance, I think it doesn't. You can decide to either wait and then repeat your basal ACTH concentration a little while later, because we know that the sensitivity and the specificity of the test is greater in the autumn. So if you have the opportunity to wait, you can wait and retest them, say, in 3 months' time, and see what the basal ACTH is then, to see if it gives you a clearer picture. You can choose to do a TRH stimulation test and look at the ACTH response to the TRH, because we know that the stimulation test again has higher sensitivity and specificity, but obviously is a sort of more complicated, more expensive test to do. Or some vets will say, well, on balance, I think it does have it, and then they will judge it on the response to therapy. So they will start the pogolide treatment and see if the animal improves clinically, and use that to sort of confirm or deny their suspicions. So there is no cut and dry answer to that one, I'm afraid. You're going to have to use your own interpretation and your own decision making to decide which side of the fence you think that individual animal falls on.
Yeah, makes sense. Thank you so much, Nicola. And there is another question here which I'm going to ask you as well. Is metformin still a relevant treatment option?
In my mind, metformin, if I'm totally honest, was never a relevant treatment option. It came from the fact that there are an awful lot of drugs that are available for the human market that get used in type 2 diabetes mellitus. So it's a very effective drug in the humans. So someone within the veterinary world decided, well, let's give, there aren't any licensed products, as I said already, for the horses. So we frequently as vets go, well, let's see what this human drug does in our horses, and then sort of see if it does any good. So lots and lots of horses got put on metformin, and then the scientific studies were done afterwards, and we discovered that the bioavailability, so the amount of metformin that absorbed, is very low. Only 7% of the oral dose is absorbed. 93% ends up coming out the other end and on the stable floor once the horse is defecated. So only 7% goes in the horse. And then when they looked at what that actually did to the horses, it did not improve insulin sensitivity. So they gave the drugs to the insulin dysregulated horse, and it made no difference to their insulin sensitivity. There's only one study out there that shows that maybe it has a local effect at the level of the intestines by reducing glucose absorption from the diet, but that's literally a single study with a handful of horses. So some people advocate giving metformin before you turn the horse out at pasture to try and reduce the risk. To my mind, that's not very logical, because why would you be turning a horse with insulin dysregulation out onto a pasture that might make its insulin dysregulation worse? You should be doing the sort of the dietary changes to prevent that, rather than using a drug to still be able to turn it out onto the diet that you know is not suitable for it. So yes, in my opinion, there is no place for metformin. But I mean, that's my personal opinion. You might get some other people that have a slightly different slant, but yeah, I'm not a metformin fan.
Thank you, Nicola. We have a question which I'm going to direct to you, David. It's how can I contact my local bioMeri representative?
Great question, Saj. In fact, there are multiple ways that you can get hold of us. We're actually in the early stage of launch, as you know, as was mentioned, Pierre mentioned, UK, Ireland, and France. So in that circumstances, there are several ways to contact us. We can go through the website, of course, direct contact either with Saj, who's business development for UK, Ireland, and myself on a sort of global role, but with a specific on the France side. As you've probably seen, we're quite active on the LinkedIn as well, so you can reach out to us through LinkedIn and also through this actual webinar, obviously invitation, there will be an option as well with regards to reach out to us. And as Pierre mentioned, we are actually moving out into rolling out as we talk into new markets across Europe and further afield. As a starting point, we can, both Saj and myself would be the contact point, and then we can sort of link you up with local teams and accompany you through that interest, further interest with regards to finance.
Perfect. Thank you so much, David. I'm mindful that we are coming up to the end of the hour. So if I can see there are some questions that we still haven't got around to, what we will do is reach out to you directly after this webinar to answer those questions, and we can share some of those answers with everyone in a follow-up communication as well. If we just move on to the next slide over here, we also have a QR code which actually feeds into what David mentioned about reaching out to your bioMeri representative. There is an option here to share your contact details if you'd like the team to reach out to you. We're also very keen to get some feedback on the webinar itself, on the pre-recorded segment, which we hope was a more enjoyable experience for everyone. But all of your feedback helps us to create more content and more webinars in the future or events that may be of interest to you. So please do take the time, if you have a few more minutes, to scan the QR code, give us some feedback. There are 5 quick questions, and if you would like the team to reach out to you, then it's an opportunity to share your details so that we can contact you as well. With that, I would like to thank everyone for joining us this lunchtime. A massive thank you to our panelists, and we will hope to catch up with everybody at some point in real life soon. Take care, everyone. Thank you.
Thank you very much.
Thank
Take
you.
care.
Bye-bye.
Bye-bye.